Hello, I'm Rocky Chapin, President and Chief Executive Officer of the Benedictine Health System, the new guy. I've been doing this since January 1st of this year and have had the opportunity to visit many of our facilities, and I'm going to share with you a little bit about those visits. But the main purpose today is to talk to you about our strategic planning effort and the results of that strategic planning effort to give you a sense of our direction going forward from now until 2020. And so as the new guy, only having been on board for about 9 months, one of my first initiatives was to visit all of our facilities, and I can report that that has been somewhat successful in that many have been visited, and you can see from the next couple of slides that will show up on your screen shortly, you can see the facilities that I visited and those that are yet to be visited as we move forward. One of the most wonderful things of these visits is it reminds me every time that the real work that we do is serving residents and families in the communities in which we reside as BHS. And it's, I think I actually receive more benefit from them than anyone else. Next, you'll see some pictures. This picture is of Benedictine Health Center at Innsbruck. You see me holding what is actually a little baby doll. And it is so realistic. It was a gift from a donor, and it's used for people suffering from dementia, and for some women particularly, it's a very comforting thing to be able to hold a baby. As a brand new grandpa within the last 3 weeks, I can tell you that as I held that little baby, it was like holding the real thing. I found myself unconsciously feeling for the toes and the fingers, but I can see where it's very helpful and could be very therapeutic. The next is the visit to Grace Living Community of Glen Oaks, where I was greeted with a mannequin you can see in the picture there that had Rocky emblazoned on the sweatshirt. There's Jim Lane and April, the director of nurses, were there to greet me. The whole staff actually greeted me with a song, an old hymn that had to do with a rock. But at any rate, it was just a wonderful expression. Lest you think that they're all fun and games, as it would suggest in this picture at St. Crispin Living Community, where we're obviously in the midst of a birthday party, you can also see me giving a radio address about the future of senior care in the community of Red Wing. And that was another fun opportunity for me, in which I was honored to be able to represent BHS to one of our member communities. The next picture is at St. Eligius Health Center, where I met with a resident and a brand new RN grad from St. Scholastica. The resident was a longtime fixture at Denveld High School, and if you're from the Duluth area or know the Duluth area, Denveld is on the west side of Duluth, and it's very much a community fixture, an institution. This woman who now lives with us was in charge of registration and some other student activities, and it was so much fun to get to know her and hear about the history of Denveld High School. And finally, the last picture I'm going to share with you is at St. Isidore Health Center of Greenwood Prairie in Plainview, Minnesota. And you have to be of a certain age to understand the banner behind me, in which Rocky and Bullwinkle were prominent, and they welcomed Rocky to our campus. I can't thank you enough for the work that you do. Every time I visit a facility, I am struck again and again by the power of the work that we do and the ability that we have to change lives, to improve lives, to create living communities, and to live fully into what God intends for all of us. And so on behalf of the board and on the leadership of Benedictine Health System, a profound thank you. Next, we're going to talk about our strategic plan. Back in May, we had a 2-day board retreat in which we brought in 3 nationally recognized speakers to look at the environment, to look at the governmental kinds of pressures that we face, to look at the kinds of changes that are sweeping healthcare today and what impact they might have on BHS and its future. We had several other meetings then with senior leadership, with the unified leadership team, with other leaders. The senior management team met in a series of meetings, and every meeting we had at least an hour and a half to 2 hours worth of discussion about the plan and the planning process. We came back to the board committees in July of this year, reviewed with them the work that had been completed at that point, and then another review went to the BHS board in August to get preliminary approval of the plan that you will be seeing today. So it's been a process by which a lot of people have been involved and a lot of thought given to what kind of organization do we wish to become and in the context in which that's about to occur. I'm going to pause for a moment and consider this slide. It's a quote from Bill Gates. founder of Microsoft, and he says we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. And I think that is so true for us today. We've heard a lot about how accountable care organizations and the Affordable Care Act are going to change dramatically the landscape within we live. There are pundits out there, experts now in healthcare, that suggest that a third of our industry will turn over, will be disrupted, will be provided by different people in different settings at different price points than we're currently doing today. Some people think that's going to occur within 5 years. I'm not sure the time frame. Could it be in the next 2? Could it be in the next 5? But certainly, I would suggest by the next 10, we will look back and say, what a ride. What a significant difference we see in the provision of healthcare services 10 years from now than we do today. We're in that in-between time. We're planning for the next 5 years, and so it becomes a bit of a challenge for us. Now, where we are today, as an organization, we have over 60 long-term care facilities in 6 states. We have about 3,300 licensed skilled nursing beds. We have about 2,300 moving to 2,500 housing with services or assisted living, independent living facilities. And home and community-based services we provide mostly out of our campuses to about 1,300 people a day. So it's a pretty large organization. We have about 5,500 total employees. You know, a very successful large organization as we stand today. We, as noted, there's a map here that shows our facilities and their locations. As you can see, we're pretty much an organization that's focused in the upper Midwest. And so moving ahead, as we look back though on 2008, what did we look like and how did we expect to change? At that point, we had more than 70 long-term care facilities in 40 campuses. We had about 4,000 skilled nursing beds compared to about the 3,300 we have now. We had 2,000 housing with services units or assisted living. That has grown to about 2,300, moving toward 2,500. Our care at home was very minimal. We didn't do a lot of services outside of our own facilities. Our end-of-life care program was incorporated in our nursing facility programs. Really didn't have any special emphasis, even though we were dealing with a lot of people and their families at that stage of life. Our payment was based on per diem rates. Medicaid at that point was manageable. We actually were reimbursed fairly well and covered our cost with the Medicaid reimbursement. Medicare short stay, where we have tended to be able to have a marginable or a business within which we create extra resources for our use, was only about 15%. And so it was expected to change quite a bit. What we wanted to have by 2015 was about 80 facilities in 50 campuses. And we have fallen short of that dream because of the realities of the market and some other reasons that I can talk about as we move into our strategic planning effort. But we thought we would be a little bit bigger than we are. We thought we'd have fewer nursing facility beds than we do, with a focus on post-acute care. And we expected, instead of the 15% Medicare, that we would have in the range of 30 to 50% of our revenue would be associated with that, or as the slide says, 40 to 60. You can see we were moving in that direction, felt that would change dramatically. Well, it hasn't changed quite as much. We're closer to 20% today as we look at where we're at. We thought we'd be higher than we were in housing with services or assisted living at 3,000. A reminder again, we're about 2,300 moving to 2,500. And we expected to serve about 1,500 people in their homes or in their home settings. And we're just short of that. So we were going to get to that point with a strong care coordination model aligned with the different dioceses and the parishes, and providing a model of informal care support. We worked on that with Catholic Senior Services, using the Archdiocese of St. Paul and Minneapolis as our first beta site, if you will. And while there's exciting things to report there, we aren't quite far along as we expected to be at this point when we were doing our planning before. We also specialize some of our care relative to end-of-life care and memory care with more focused programs on those kinds of conditions. Now, when we're planning a major remodeling or looking at a new project, memory care is often a significant component of that. And I think you all know the statistics that they're projecting that if you're over 85 years old, a third of us at 85 plus will be suffering some form of dementia. We also expected to be, by 2015, fairly deeply involved in at-risk, or what we call integration of payment, where we would accept more risk from accountable care organizations, from public funders like the state or the federal government, and that we would be subcontracting some of the risk as a post-acute long-term care partner of the accountable care organizations. That's been one of those Bill Gates kinds of phenomena. It hasn't changed as much in that initial period as we expected that it might. I was at a national conference here this summer and learned that there are no known contracts between long-term care providers and accountable care organizations relative to the sharing of risk in an accountable care model. We are in the process of beginning to work on that with our partner Allina and the product called Interlude Restorative Suites. That, however, is still not completed, and much work remains to be done on that front. But that was something we expected would be much further along than it has been. I do, however, as a side note, see that will accelerate now in the years to come. In terms of enhanced partnerships, we continue to work on that, although we've had several. We were thinking hospitals and health systems would be partners for us, other Catholic healthcare providers, Catholic dioceses. We have stepped into those waters in some ways, in a big way, relative to some of the partnerships. For instance, I reference frequently Allina, but also Health East, Heartland Health at St. Joe, Missouri, and we have some great opportunities offering themselves to us now for enhancing those partnerships and expanding into new ones. Capital formation, financial sustainability is an area where we felt we would have reached sustainable system financial performance. I can say, unfortunately, that reality kind of bit us. We didn't quite achieve that as we expected. In fact, last year we had negative cash flow, which is not a good sign for any organization. Even though our income statement looks a little bit better than it did the prior year, we have not yet reached a point where we feel we have a sustainable financial model going forward. There are some changes that we're anticipating as a part of this planning process that address that, and I think will put us on firmer footing moving forward. We also felt that we would have created a larger capital fund and a strategy for raising even more money firmly in hand by 2015. There would be a larger equity pool. Our strategic capital fund would be larger. We've set aside some money with that, and we've actually been using it. In fact, in the last 18 months, we put about $74 million worth of new projects or renovated projects into the market. It's a significant investment for us, but it took also some significant capital. And so we're going to need to work as we go forward in replenishing that supply. Philanthropy is a bright spot. Lowell Larson's team and the foundation board has done just a masterful job of bringing community support forward, such that we're seeing anywhere from $5 to $7 million a year in additional support, much needed support with communities stepping forward. We also thought that we, by then, would have changed our debt leverage and our coverage ratios relative to debt. In other words, how much debt we carried going forward. We continue to carry a significant amount of debt, and that is something that we're going to have to look at again in terms of restructuring. So for a planning process, what you really need to do is really focus on what do we know now? What is our understanding, and what are the assumptions then we base a future sense on? And so what do we know now in terms of care? And what we've done, by the way, is we've organized our strategic planning in the familiar pillars. So care, service, people, finance, and growth are the pillars that we look at when we, are the domains, the areas of focus for us going forward. And so in the area of care, we know that the availability of caregivers is a significant issue for us today, and we anticipate that it will be moving forward as well. When I visit facilities, I would say the last half dozen, when I've asked what is the first or what is the major problem you face today, more often than not it's staffing. Now there's some variability. Sometimes the staffing problem or the staffing challenge is in CNAs, sometimes it's in physicians, sometimes it's in RNs. So it's not the same across every community, but in every community we have a staffing challenge. And in some communities we've even turned away admissions because we don't have the staff to care for them, or in some cases we might have the staff, we don't have the physicians in the community available to take care and direct the care of the patient or the resident. So these are staffing and those issues going forward is a major challenge for us. Another one in terms of caregivers, staffing levels, is competencies. What we're seeing is a shift from acute care to post-acute care to home care. And so that shift is characterized by the level of acuity is moving away from higher cost settings into lower cost settings. And so today, many of our skilled nursing facilities are caring for people that just 5 years ago would have been inpatients in a hospital. Many of our assisted living communities are taking care of people that not that long ago would have been residents in a skilled nursing facility. And so as we go through that change and respond to that change in the market demand, we are going to require a higher level of competency and skill in settings where we've traditionally not had to worry about that. And so one of the fascinating things, or the good things that has happened, is as you look at the Clinical Support Services group, they're adding a RN to work with assisted living and independent living settings to make sure that our clinical competence there are at competencies are at the level that they need to be. The acuity of care, I think, will only increase in all of our settings, as I mentioned earlier. Quality outcomes are going to be very much a part of our world. We are going to have to be able to report how well we're able to help people, that their outcomes, their clinical outcomes are superior, and we will be graded on that and reported on that in public media as well as professional settings as well. And so bottom line, the preferred sites of care will continue to shift toward less regulated settings at lower cost. Technology is not one of our pillars, but it's important enough that we pull it out as we have here in this slide. Electronic health record. We use Matrix. We are going to have an ability for Matrix to connect to Epic, Cerner, the kinds of electronic health records used by the major health systems. Because it is through those connections that we can make sure that errors are diminished relative to the transfer of information, but as well that the information is available in the way in which the provider is most used to seeing it. And so we've done some neat things with state grants and other work that we're doing today to make sure that we connect with Epic, but we don't have Epic in all of our communities, and so we're going to have to do some other things to connect with that acute care systems electronic health record. We know that robotics and sensor technology will also be a much larger part of our work, both in terms of sensing residents and guests and families in their homes or in our settings to make sure that they remain safe, that their vitals are monitored on a regular basis. Those kinds of things are what we're talking about in terms of sensor technology. The other area is what's called ELTC or eDoc. And these are ways of connecting providers, whether they be physicians or nurse practitioners, from a distance. And that allows us to be able to provide that level of oversight, perhaps not in person, but be able to get over the hump of the challenge of time and distance that separates some of our more rural facilities. And so we see we are able to provide then a higher level of care and coverage than we might otherwise be able to do. Data analytics and reporting is sort of that big data thought, that we have a lot of information that we're gathering now on a regular basis, but how do we use it is a strategic question. If we use it well, we can benefit those that we serve. If we don't take advantage of that, others will, and we will have be placed at a disadvantage in the marketplace. We know that social media is a big player now in our brand and in how we're perceived. I heard an interesting statistic recently, and it just sort of blew my mind. When asked, where do you receive your healthcare information, 94%, nearly everyone responded, Facebook. And you go, Facebook? I was expecting to hear WebMD. But no, it's Facebook. And why is that? If you think about how we identify good providers when we move into a community or when we're faced with a challenge, who do we turn to? We turn to our family members. We turn to friends. We say, who do you think is a good doctor? Who do you think has a best facility for mom? Those kinds of questions. And so we go to a circle of acquaintances. Well, Facebook is basically that on steroids. And so it does, in retrospect or in thinking about it, it's not surprising that 94% of the people turn first to Facebook when they're looking for information about healthcare. We need to be very much in that kind of setting as well. And we need technology to support automation of our key processes. You'll hear more and more as I talk about one BHS, but this idea that if we can have technology assist us rather than harm us, but if we can work with it in a positive way, we can find some more economic ways of serving those that we think we can serve best. So what do we know about service as we look at that area? Brand is important. If we can differentiate ourselves, if we can provide value that is very distinctly different than everyone else's in the crowded marketplace that we are, if we can provide a consistency of customer service, that brand experience, then being BHS means something that we can deliver favorably across all of our settings. And I think that's something that's a little bit of a different focus than we've had. We've tended to say very much, well, healthcare is local, which is very true. But if our brand of local healthcare is such that it's powerful, that it's engaging, that it's perceived in a positive way, then more people will choose us, which in a crowded marketplace will allow us to be financially sustainable and successful in serving our mission and our ministry than if otherwise were the case. So again, it's the sense of technology is important for us to be just as effective as possible in serving those we would wish to serve. What do we know about people? This is an area of mostly internal. We know that the demographics of those served and those serving are changing. The baby boomers are going to have already dramatically changed society. They will continue to do so as they age into their 70s and 80s now going forward. But we're also seeing that in our leadership. Many of our leaders are people in their 50s, sometimes late 50s. Many of those who serve are of a demographic that reflects the impact of the baby boomers moving through society. And so that makes for some important distinctions that we have to work with. One of the underappreciated facts, I think, and we're having to deal with it in the next 5 years, is the fact that there is a lot fewer people born in the 1930s than there was in the 1920s. And so those who have been born in the 20s and are now passing on to their Redeemer are not being replaced by people who were born in the 30s to the same extent. And so as a result, we see 5 to 6% reduction in demand for our services, particularly at skilled nursing. Now what's fascinating is that's the exact same number that we see in hospitals today. And so everyone is experiencing this reduction in demand. And in us, it's amplified by the fact that now not only is the demographic shifting, but the site of care is changing. So we're seeing more and more people choose assisted living rather than skilled nursing. And what we need to be prepared to do, I think, as we respond to this, is how can we best meet the needs of people who are coming out of the hospitals. Even though there are not as many of them, they're coming out sooner than they would otherwise. We also know that engagement is extremely important. And one of the factors that drives engagement, that drives why we come to work every day, why we think the work that we do is important, and why we think we're good at it, has to do with the leadership that is provided. And so leadership development is an area that we need to really focus on going forward, because we believe that it's key to recruitment, to retention, and to engagement ultimately. Our systems need to support work rather than become the work. This is always a challenge as technology becomes more a part of the work that we do. I've worked with acute care systems for much of my career and was involved in the transition to electronic medical records, electronic health records. And more often than not, they became the definer, if you will, of how care is provided. What we have to make sure is that we define the care that needs to be provided, and technology supports that. And finally, we need to believe that our work truly is sacred. And that if we can attract people who feel called to the work that we do and know that they're making a difference, we are going to be able to successfully respond to some of the challenges we have with staffing that I mentioned about earlier. Finance. We know that the current model of funding is unsustainable. In most of our operations, specifically those with skilled nursing, we lose money. And a lot of that has to do with the level of public funding primarily. If we have a high level of public funding, Medicaid or elderly waiver in the state of Minnesota, family care in Wisconsin, what we discover is that we are losing in the range of $30 to $60 per day per patient, per resident. So that's a significant loss, and we don't see that changing anytime soon. We're going to be able to advocate for this change with state legislatures, with the federal government, but you all know the story, and the ability for them to move money into our sector is somewhat limited as well. So we're going to continue to have that as a challenge for us. New reimbursement models are emerging. This accountable care organization concept, bundled payment, episodes of care, ways in which we shift risk, or the payers, the government, or insurance companies shift risk for that care to providers. In other words, if we can't manage it well and it costs more, guess what? We eat the cost, or we have to absorb those additional costs. Those we see are coming more and more into play, and we need to be prepared to respond in kind. Our current debt is a pretty major issue for us. It limits our ability to reinvest. More often than not, we find ourselves in a conversation, mostly with ourselves, but it says, we would like to invest in this particular facility, but we can't because we have too much debt. And so we're going to have to figure out, how do we change our debt structure in a way that allows us to look at each community and the opportunity that it might present to us based on those merits, rather than, well, we can't do it because we have too much debt. We know that private pay, or what's called market rate margins, are sustainable. In other words, if people will pay us full price, we can do fairly well. In contrast, public reimbursements are not. So that would suggest a challenge to us in terms of, can we meet our mission of serving those who are underserved and in need, and how do we fund that? Because we know if we try to fund that, we do it at a loss. So is it philanthropy? Is it cost shifting? It's a phenomenon that has occurred in healthcare for a long time, but what that means is you have price-paying people paying slightly higher so that they can cover the losses of those who can't afford it. Those are something that we're going to have to address relative to finance. In terms of growth, growth is, number one, we accept that growth is important. Let's start there. Our business model today is mostly facility-based, and that means we have high capital and carrying costs as a result. If we could provide more services to more people without that much capital requirement, there would be money left over for margin. But how do we move from where we are today to where we might need to be? We know that change will require reinvestment. We don't have the margin right now to say the profits will allow us to reinvest. We do know, however, that philanthropy is strategic, and that's why you're going to see a continuing focus on, as we move forward, on philanthropy and community support. If we truly believe that healthcare is a right and is something that's necessary for a vital community, then indeed we need to look to those communities for support. And we do that when we create relationships with them. And so that's going to be something that we'll need to be focusing on. Now, growth will also require solid systems and a term called scalability. And what that means is that we can take on more facilities, we can serve more people, and it means that for each 10% increase in the number of people served, we don't have to increase our costs 10%. If we could, scalability is we can take care of 10% more people with only 5% more cost, something like that. But we can get there if we have good solid systems, if we have solid leadership, and if we innovate. And innovation is a theme that you'll hear more about in just a few moments. So how are we challenged? And well, we've identified 5 key challenges. They're also beginning now to tell us and give us hints for our strategic direction going forward. So a challenge is not only a challenge, but it truly is an opportunity as well. I sometimes get a little frustrated with people who say, well, I have a lot of opportunities, when in fact they mean, well, I have a lot of challenges. In this case, I think it's true. The way we've created our statements on how we are challenged are really sort of setting our strategic direction. And so our first one is we need to reset our fundamental business model and our practices so that we become more efficient, effective, and innovative, and thereby lead the transformation of healthcare. We did have a conversation at the board meeting where we discussed this, and the question was asked, is it right for us to consider ourselves leaders in healthcare transformation? And the conclusion was yes. If not now, when? If not, who? Why not us? Those kinds of discussion and belief that we have something to offer drove the fact that we do want to lead the transformation of healthcare. We don't want to be led by it. We don't want to always be responding to it. We want to be innovative and effective in our response to the changes that are occurring. Challenge 2. We need to recruit, engage, and develop a workforce motivated, skilled, and trained to meet the needs of those we serve across all settings and across the whole continuum. What that is recognizing is staffing is very important for us. And we're going to have to figure out some different ways of making sure that we have the staff available to take care of those we serve at the level of care that they require. We are challenged as well to create or adapt existing partnerships to extend and advance all aspects of care. This is not about any old partnership. This is effective partnerships. We have some. Sometimes we call ourselves the Switzerland of long-term care because of the number of partnerships that we enjoy. But we're also going to have to be prepared to change the ones that aren't working as well as they were originally intended and to adapt new. You might ask, why even partnerships in the beginning? Why can't we do this alone? Well, great things cannot be accomplished alone. And if you look at some of the realities of our balance sheet, our income statement, some of the other resources that we have, we will be able to accomplish much more if we have others at our side. To do it alone is just something that I don't see us being able to accomplish. But partnerships provide us a way forward. And so we need to be very good at extending and advancing those partnerships so that the care and the mission is extended as well. Fourth, we need to focus on creating a distinctly BHS experience that encourages a memorable, trusted relationship with those we serve. Originally, that statement was cast in the brand. We have to have a strong brand. But I like the word distinctly BHS experience. What is it about us that when you walk into one of our facilities or receive services from one of our associates that makes us so distinctive? And it's the way that we do it. It's the spirit with which we do it. That is really part of the brand promise. And I think that's a challenge that we need to respond to if we're going to compete effectively in this market. And fifth, we need to fund mission growth and depth by generating a sustainable operating margin. You might ask, well, isn't that a tactic? You have to have that in order to achieve strategies. Well, we've elevated it to a strategic imperative or a strategic level because we think it's so important. Without this sense of resources, we cannot extend the mission. We cannot grow the ministry. There is a sister that I was acquainted with when I worked in Iowa. She was the head of Mercy Health System in Des Moines, Iowa. And she would often tell her leadership team, our goal is to serve the poor, not to become one of them. And so it's the old play on margin versus mission, but without margin, we cannot achieve the mission. And so we cannot serve others unless we are healthy and well ourselves. The next several slides are going to be showing you what our strategic objectives are for each of the pillars. We'll start with care. And you can see that we are challenged. We have sort of a crosswalk in this graphic. And so we're challenged with our fundamental business model and practices, and we need to create or adopt our partnerships. And so the objectives, we have two. The first is that we need to achieve superior clinical and spiritual care outcomes at the 75th percentile, which means at the top quartile. In other words, we want to be able to look at ourselves and be able to express to others that we perform at the top level of providing care. The second is the BHS Innovation Center, which was recently founded by and supported by the BHS Foundations, will be recognized for its practical approach to identifying and implementing innovative practices that make a difference in the lives of those engaged with BHS. A couple of things that are important for us to remember here. This is about practical application. It's not about basic research in terms of the innovations. And we want to implement those practices in ways that make a difference for those we serve. So it's a very much of an applied, a practical way of looking at ways we can change things so that we do them much more effectively. And you can see then on the far right column some of the tactics and actions that we will need in our next step of planning to really specifically identify for each year going forward. And so these are ideas that are currently on the table. Which ones will rise to the top is part of a process that will occur after September. Now we move on to the pillar of service. And again, two strategic objectives. The first being that satisfaction responses from those we serve will be at the top quartile. In other words, we will be in the top 25% of those across the country providing services like ours. And the second part of that is we will provide a carefully selected set of services that meet individual needs while improving health and wellness of all those we serve. There's some important elements to that. The first is that we will choose which services are best provided and need to be responsive to the individuals we serve as well as the communities that we serve. Again, some important elements there. Moving on, we come to people. And again, remember the challenge is to recruit, engage, and develop a workforce motivated, skilled, and trained to meet the needs of those we serve. Engagement is a theme that is beginning to run through this, if you've noticed. And we believe that engagement is enhanced when we have effective, solid leadership. We also know that it's going to be important for us to grow our own. We aren't always able to look to the outside for our next talent pool. We're going to have to look inside. We're going to have to look into a group of people who we believe are engaged with what we do, who believe in our mission, who follow our values. And if we can make sure that we recruit people that can buy into that and then support it moving forward, they can become the beginnings of our core group of leadership. And so we've set ourselves a pretty big, hairy, audacious goal. And that is that 80% of our leadership positions will be filled from within. Now think about that. If we're going to have nearly all of our leadership positions filled from within, that means we have to have a bench full of people prepared to take the next step. And where does that begin? I would suggest to you it begins with that first hire of that aide or that housekeeper or that dietary aide. It's at that level that we need to make sure we're hiring people and we're identifying people who will work with us because they believe in the work that we do and are committed to it. We want then employee engagement, again, to be at the top quartile. So you're picking up a theme that when we compare ourselves to others, we want to be in the top quartile. And in order to do that, we need to make sure that we have career tracks for development. We need to have leadership development activities that actually do develop leaders. And we need to look at innovative ways of organizing our work so that we have the resources and the time to commit to leadership development. Finance, the kind of thing that without cash, we can't meet payroll. Okay, so if we take that as a given, then what we have to do is achieve an annual net cash flow of 4% of gross operating revenue. 4% is a fair amount. We have had opportunities to do 10%, 12%, 14%. So we think on average a 4% net cash flow is a good thing. That would allow us to invest in new services and products and facilities while maintaining current operations. The next strategic objective is that we'll have 90 days cash on hand. Now, that, quite frankly, we have some of the people in our space, competitors of ours, that are over 100 days cash on hand. Some of them over 120. We have chosen 90 days because we think it's a sweet spot. It suggests that we will not use all of our cash just to bank it, just to have it, but that we will be investing our cash. But we need to have more cash than we have today. And so that's about 30% more than we have today. So right now we have about 60 days cash on hand. We need to see that grow to 90. And part of one of the strategies that we might consider to do that is to restructure our debt. Right now we have interest rates at historic lows, and if we can restructure our debt at a lower interest rate, we have the opportunity then to save money that allows us to build cash. Finally, growth. Many organizations sometimes confuse growth as surviving or thriving, and so growth becomes its own means to an end, growth for growth's sake. We don't see that at all. We see growth as an expression of our response to Jesus' call to go therefore and spread the good news. In our case, the good news that we spread is the healthcare ministry of the Sisters of St. Scholastica Monastery. That's the mission that we provide, care of the sick. And so if we are growing that, we are growing the kingdom of God. One way to think about that. And so how do we do that? Well, we expand our post-acute care rehab through partnerships with integrated health systems. We are going to respond more and more to healthcare systems who need our services, who need our help. The giants are waking up and recognizing that long-term care, senior care, post-acute care has a pivotal role to play, an important role to play in population health and in the care of people going forward. We need to make sure that we are players. And so partnerships will continue to work on that. We'll continue to find ways that we can improve our current partnerships and expand into new ones. And growth will also occur when we provide individualized care through the development of specialized programs and services. And we've shown a list here. Rehabilitation with orthopedics, cardiology, pulmonology, dementia care, palliative care, home and community-based care, all represent areas of growth for us. And we think we can do that not only in each of our facilities, but across regions, and potentially, as we're being approached now every week, nationally. So we do think we have some opportunities to serve a much broader group of people than we're serving today. So you might be asking by now, so what does this all mean? Well, it means that we need to come up with some kind of memorable narrative, some kind of statement, some way of expressing our plan in shorthand that says we are moving forward in a very positive way and that it has meaning to us, and we hope it has meaning to you as well. As we went through various discussions, I was asked this question. Well, Rocky, you know, I've worked other places, or I've worked even here. Sometimes is how it's expressed. And you know, we've said these things before. What's going to be different this time? Will we actually be able to achieve these strategies? And my response at the time was, well, if we want to, and if we work together, we can. And as I've thought about that off-the-cuff response, I think I really kind of may have hit it, because it speaks to focus if we want to. It speaks to will and desire, and it speaks to if we work together, if we have partnerships, if we believe in ourselves, not just in the leader. Because this isn't just Chapin. This isn't just me. This is all of us need to buy in. Now, we're informed in our response by our mission. And the beauty of our mission is it doesn't change at all. The Benedictine Health System is a Catholic organization entrusted with advancing the healthcare ministry of the Benedictine Sisters of St. Scholastica, Duluth, Minnesota. Our mission is to witness to God's love by providing compassionate quality care with special concern for the underserved and those in need. That mission, that ministry does not change. The next slide is about our vision statement. Now, you might ask, what happened to values? Hospitality, respect, stewardship, justice. Well, guess what? Many of us wear them on our wrists today, but many of us have it written on our hearts. So I didn't take the time to even cast a PowerPoint slide for you to have our values on it, because I think it's quite redundant. We understand that, we live that, we know that as people. But our vision statement is changing. And what was the old one? We have to start there. Creating Benedictine living communities where health, independence, and choice come to life. Now, we've changed a few words. And in fact, I've even highlighted in blue one of the words. But now we say we create Benedictine living communities where health, wellness, and choice come to life. Two changes. We and wellness reflects this idea of engagement, that we and those we serve have to work together to achieve this vision. It's not something that we do alone, which creating Benedictine living communities might have suggested in the past, that we do all the work. Well, no, it's we working with those we serve. And it also includes this statement that it's us. We are also involved in this very definitely. Health, wellness, why did we change independence? We moved to wellness because we feel that independence could almost be interpreted in a negative kind of way. I'm losing independence because I'm coming into this community. Well, here we're now celebrating wellness. By joining us, by joining our community, you're going to become well. You're going to have health, and you're going to have choice. And that doesn't apply just to those we serve, but it could also be those of us who work within the Benedictine Health System. It's a place where health, wellness, and choice come to life for me as a provider. Now, why is living in blue? Why is living kind of held out? Between the board meeting and this meeting, we've had some discussions in leadership. And the thought is, do we say living communities? Do we focus too much on facilities? It's where you live, rather than the sense of communities. And so what I did at the leadership conference, and what I would ask you to do here as well, is consider, should living even stay in the statement? Does our vision include developing a community where we're serving those where they live, wherever they are, rather than in one of our facilities? But that's an open question, and hopefully by the time you see this, that may have been resolved. And if not, I would like to have you have a discussion with those with whom you're watching this to say, does living limit our vision for the future in this statement? But anyway, as it stands, it's our new vision statement: we create Benedictine living communities where health, wellness, and choice come to life. And we've also developed a tagline. Now remember, I talked about social media, I talked about the brand experience, I talked about how can you quickly differentiate yourself from others in a very crowded marketplace. You may recall that we have, over the last couple of years, talked about the purple cow. This idea that a purple cow would stand out in a herd of Holsteins, right? Well, how do we have BHS become a purple cow? How does BHS stand out in a herd of Holsteins? What makes it different? And how can you suggest that? How can you state that in a memorable kind of way? And so a lot of organizations use taglines. It's something that would show up on, in conjunction with our logo. It would show up on our websites, and it would help express an idea about how the BHS can meet your needs. And there now, the tagline would be living fully, living well. You don't come to our facilities to die. You don't come to our facilities to recover. You come to our facilities to live. You come into our services, whether they're at your home or in a facility, to live fully and to live well. And so that is the excitement that I feel about our new tagline of living fully, living well. You can see that as our value proposition. You can see that as, this is what we promise you. Is any interaction with a Benedictine Health System associate means that you will be living fully and living well. And if you are an associate, if you are a person who works for Benedictine Health System, you too have the opportunity to live fully and live well. So what's next? Well, one of the very first things that we're looking at is a restructuring of the organization's leadership to better respond to the changing dynamics and the environment as we saw them expressed in our strategic plan. And so what you see is an organization structure that will go into place following our leadership conference in September. It's built on a foundation of our Benedictine mission, vision, and values that we just went over. It will use the pillar construct. In other words, we'll look at our focus in terms of care, service, people, finance, and growth areas. We will continue our quest for the Baldrige Award. So a way of thinking about how we can improve care, how we can improve our processes with Baldrige criteria. We will continue to do that. So that's part of our foundational elements. And the idea of one BHS. Originally, when that was talked about, it was in the context of standardization. But really, one BHS is about breaking down the wall that separates corporate from facilities. That might separate us from our communities. One BHS means we are all working together to make sure that we are providing the services that are needed. So one BHS, we have some common systems. That allows us to be more creative and more innovative if we don't have to keep reinventing the wheel over and over and over. Now, I'll only point out a few of the changes that we see in this chart. First is what we've added is a Senior Vice President of Clinical Services, or a Chief Clinical Officer. That voice needs to be at the table. You'll also see the Chief Medical Officer. Because of the increasing acuity of the people that we served in the different settings that we have, it's more and more important that we have clinical at the senior leadership table. And so that's the reason for that addition. The other addition is a Senior Vice President of Information Technology. That's a new position, and that's one in which we really focus on, do we have the technology resources that are necessary to enhance and expand our electronic record, to respond to the needs of sensing technology in the home or in our settings, as well as the exchange of information going forward. not only with others that we are partnering with, but within our own organization. And we need to take that up a notch from where we are. We spend, as you know, about 1.2% on technology today. That's very competitive in our industry. I'm not sure that that's going to be enough for us as we go forward with the imperatives of change. The other piece that you see, the other box, is Senior Vice President, Leadership Development and HR. We call out specifically human resources and people as an area in which we need to do much more of a focus than we've had. And you can see the sense of leadership development takes first line, HR second line. And that's simply not to say that one is more important than the other, but to say that there will be a focus on leadership development for the organization going forward. And so that's the organization structure that will go into place. We are actively recruiting for the Senior Vice President Operations. The Senior Vice President Institutional Advancement and Strategy is a position currently held by Lowell Larson. And as you know, Lowell will be retiring in January of next year. And so we've begun the search for his replacement as well. And so we're looking at populating these boxes, if you will, these slots in the organization, and that will give us, I think, a sound organization structure moving forward. That completes my presentation. Please continue the conversation and look for ways in which, how can I support this and what can I do to be a part of it going forward? Thank you so much.